Is everybody ready?
Yes, sir.
Please,
Good.
please.
Great. So the first question is regarding a 34-year-old lady who presented with pain and stiffness in the shoulders and wrist over the last 3 months. So what this question is telling you that it is a symmetrical involvement. So both shoulders, both wrists, and started quite together mostly and in last 3 months. Worse in the mornings. Now this is important as well. It's telling you about the inflammatory pain. So it's a very important thing for you guys to remember is that worse in the mornings is usually inflammatory, although not always. Now, clinical examination for this patient revealed synovitis of both wrists and impingement of both the shoulders. Now, synovitis is a definite clinical terminology we use on our examination findings where we think that there is thickening of the synovium, possibly inflammatory. So you need to think of that as well. No proximal muscle tenderness or weakness. So in this line, the examiner is ruling out any major muscle pathology. Blood reports show the erythrocyte sedimentation rate of 56, which is high, and we don't have immunology results yet. So they're not making it too easy for you by giving you immunology, because this is more of a diagnosis question rather than a management question. So options are either is it reactive arthritis, rheumatoid arthritis, polymyositis, PMR, or SLE. Right, guys, what do you think? Well done. That's what I was expecting, actually. I would have been a bit disappointed if anybody ticked anything other than rheumatoid arthritis. Straightforward. What you have is a young patient, lady. So this more common presentation is females. You have symmetrical involvement of shoulders and wrists with stiffness, worse in the mornings, and you do have definite clinical synovitis with raised inflammatory markers, no muscle involvement. So you're ruling your polymyositis out. With the age criteria, you are ruling polymyalgia out as well. Normally with the SLE, we get arthralgias rather than a true arthritis, although there is a possibility. But when they ask you the most likely diagnosis, that would be rheumatoid arthritis. If they would have given a picture of an infection here, for example, then again, you could have thought of a reactive arthritis, but usually that's not symmetrical either. So in this scenario, the most likely diagnosis was rheumatoid arthritis to begin with. And well done. Very good. Right, we can go to the next one. Great. So next question. 60-year-old lady came in with polyarthritis for last 6 months. Clinically, she has symmetrical inflammation with painful movements of the hands and feet, so smaller joints were involved. Also, there was swelling of the knees as well, and they are now giving you the diagnosis that it is most likely rheumatoid. Now, which of the following suggest adverse prognosis? Now, you have to think about adverse prognostic factors with rheumatoid arthritis. Number one, chronic presentation. Number two, raised CRP, enthesitis, seronegative for rheumatoid arthritis, or erosions on X-ray. I think you guys have answered very quickly about that anyway. Can we have a look at the answers? Right, okay. So erosions is the true answer. Seronegative usually has a slightly better prognosis compared to seropositives. So that would not probably be adverse prognosis. If you have rheumatoid factor and anti-CCP positive, you're more likely to have erosive disease as well. So erosions are common with seropositive than seronegative. And on presentation, if you already have erosions, that means that your onset of arthritis wasn't very early, so already 6 months, so you already accumulated damage. So getting a full remission in that scenario is not easy. High CRP could well be uh, 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 poor prognosis. Chronic presentation could be a poor prognosis, but most likely or worse outcome is with the erosions rather than seronegative for rheumatoid arthritis. In fact, if you compare seropositives with seronegative rheumatoid, seropositive is poor outcome, and that is usually associated with erosions as well. So in this scenario, erosions on the X-ray at presentation is a very poor prognostic factor and tells you that you need to treat this patient aggressively. And it does tells you that most likely this patient is both either both rheumatoid factor and CCP positive, or at least one of those.